Welcome to the Menopause and Cancer podcast, and welcome to our HRT After Breast Cancer mini-series. My name is Dani Binnington. I'm the host of the Menopause and Cancer podcast, and I speak to hundreds and hundreds of cancer survivors who are pushed into the menopause because of their cancer treatment every single month. One thing that many people talk to me in a hush-hush type of way is, I'm curious about HRT after breast cancer. I don't know where to go. I feel shut down. And many of my doctors have refused me to have the conversation, which is why I wanted to host this HRT After Breast Cancer mini-series. So if you're landing on this episode, please make sure to go back to episode 1, 2, 3, 4, and 5 to learn the basics, the foundations. What studies do we have to date? How do we move forward? Most importantly, without perfect data, how do we help patients? How do we support doctors? And today I want to talk to a couple of amazing patients, because HRT after breast cancer isn't just one thing. It's not just estrogen and progesterone after an ER positive breast cancer. Some people might want to pursue testosterone. And today I also want to talk to an amazing patient who is pursuing testosterone pellet implant therapy while she's on an aromatase inhibitor. So it's really important to know that sometimes we talk about very many different things. We talk about things at different times. You'll hear from one of our patient examples today. She wants to talk about HRT after breast cancer quite soon after her initial diagnosis. And in some cases, it takes 15, 20 years when women want to know more about their own risks versus their own benefits. But today's conversation is much more about, how do we feel as patients? Do we hold the risk as patients? Can we share it with our doctors? Do we feel heard? And how do we make decisions? Because I think that is much more interesting than really thinking, what decision is everyone making? So please come into this conversation with open ears and an open heart. These amazing patients are so wonderful for sharing their story. And so let's welcome them in now. Well, I want to have a conversation with two very brave women today. We just talked about that a little bit in the pre-recording before we pressed OK. And we also spoke about what a wild field it is out there for anyone who wants to try and even think about or consider the use of hormone replacement therapy after a breast cancer diagnosis. And I really want to highlight with today's conversation, it's not just one thing. It's not one thing people might consider 15 years on from a cancer diagnosis, and it's always progesterone and estrogen, because it's not. So, Lisa, we're going to start with you a little bit. How are you today? How are you feeling? And I want to ask you a little bit about your journey, if that's okay.
Yeah, that's great. Thanks for having me. I feel great today. I feel top of the world. I feel happy and positive. My journey with cancer is I'm a pretty fit person. I had no idea. So last February-ish, maybe a little earlier, maybe January, I found a lump myself in my breast. That's not correct. Went to the doctors. It's right on the outside. So I thought I'd pulled a muscle. I'm very active, do a lot of strength work. We'll get it checked out. And it was diagnosed eventually, kind of relatively quickly as a breast cancer lump. And so I had lumpectomy as always, and was advised to come off hormone replacement therapy, which I'd been on for I think about 3 years by then. Before that, I'd kind of suffered for quite a lot of years. Really bad hot flushes, night sweats, not sleeping well, palpitations. They were the major symptoms. Also painful sex, dry vagina, things that I hadn't really thought I'd recognise the hot flushes as part of menopause, because that's the kind of obvious symptom. But some of the other things, low mood, achy bones, really aching. And it was only when the flushes and night sweat started to get really bad, this is when I first went on HRT, that I've got to do something about this. Read up on lots of things, as many women have, kind of like quite a reservation about this, kind of like a last resort. So I tried everything else, nothing was working, and the doctor said, I think we'll try you on starting a low dose of HRT. And it was like almost overnight, within the week, the sweats had stopped, I was sleeping, my mood was better. So I was like, oh my God, this is a miracle. I just felt my old self back, that the bone ache started to ease, and I didn't have them anymore. Anyway, so that was back then. That's when I first started taking hormone replacement therapy. 3 years later, diagnosed with a small tumour fairly early, caught it really quickly, and had a lumpectomy, radiotherapy, 5 days of intense radiotherapy. And then I saw the oncologist, and we discussed hormone therapy and anastrozole. I think it was, anastrozole or letrozole, one of the aromatase inhibitors, because I'm postmenopausal. And I decided on risk versus benefits, because there was a very low risk of it coming back with or without the hormone therapy. I decided to have a conversation about that and with the oncologist, and saying, I'm kind of really reluctant to take it. I've had friends who've taken it, who've, kind of really warned me of the side effects that they'd had, and just to make sure that you be careful with your bones and all of this. So I had a conversation. I said, it's very low risk, and she was very keen for me still to take it, even though I think there was, in the 5 years, there was a 0.5% difference. And even over 15 years on the NHS predictor, there was only sort of 1% difference in my outcome taking it versus not. So very kind of like marginal, really. And so I decided not to take it. Saw a second oncologist the next time I went, a locum, who said, yeah, I agree with your decision on the low risk, and you're fit and healthy, and the bone aches you've had in the past, I would say that's up to you, and we will support that. So that was fine. So I kind of went away, as you do. You get discharged, and you're not discharged, but, it's kind of like no more active treatment. And then I was just getting all my menopausal symptoms back again, because I'd come off the HRT before my surgery. And with a vengeance, really. Hot sweats again, nights, not sleeping well, low mood. And I was like, I really want a conversation about starting my HRT again. So I got in touch with my GP.
Lisa,
yeah, sorry.
We're going to stop you there for a moment. We're going to stop you there for a moment, because I want to hear in more detail how that thought process was, because I really need to understand why you would have even considered going back on your HRT. I'm assuming, just for context, you had an estrogen and progesterone positive cancer. Is that true? Breast cancer?
Yes.
Yeah. Okay. Just for context, that's why you were prescribed the aromatase inhibitors. You didn't take them. We're going to talk about the next step. Yeah. No, we're going to talk about the next step in a moment. Helen, what was your experience like before you were diagnosed with breast cancer? Was perimenopause on the radar for you?
Sort of. I was 43. It was 2020, so I'm 4 years out now. It was, no, I didn't really. I'd started to have irregular periods. Libido was heading out the door a little bit, but that was it really. I hadn't labelled it perimenopause. I hadn't really thought about it. I just sort of thought it was sort of naturally changing. But when I was diagnosed, middle of 2020, remember that was kind of peak COVID time, so lots of lockdowns. It was so long ago, I can't kind of remember the order of everything, but I had a lot of chemo. I had single mastectomy. I had Kadcyla after my single mastectomy because they found some residual. My period stopped after my second chemotherapy treatment. I wasn't told, nobody mentioned the M word. I was told by my oncologist that, quote unquote, your periods might stop. And that's all she said. So when I came out of all my treatment, I went on to tamoxifen and was told this is a little white pill that you'll take for 10 years, no bother. But I found it incredibly difficult. So I tried, I read that you could take different types of tamoxifen. And so I tried different brands. I even tried liquid tamoxifen at one point, which not a lot of people know exists, but it does. Because then it doesn't have the different additives that might have been causing some of the issues. I eventually stopped taking tamoxifen because I had a second risk-reducing mastectomy, and this was kind of towards the end of 2022 by this time. I'd started to think, I don't know if tamoxifen is the problem here or whether actually I'm in a huge menopause. And I went about looking at what HRT might do for me, how safe or not safe it might be. I should say my cancer was triple positive, very high on the ER numbers. I think I was 8. But I read up on it a lot. I spoke to numerous doctors, GPs, gynecologists, oncologists, private menopause specialists. And yeah, you get a lot of different guidance and a lot of different advice on risk. And whether the question is whether that risk is yours as a patient, an educated patient who values, and I hate putting it like this, but as doctors say, who values quality of life over longevity. Because the way they see it, or a lot of them see it, is that if you take this stuff, it'll make you feel better, but it'll probably kill you quicker, is the kind of summary of how a lot of doctors see it. And yeah, so here I am now. I've come onto HRT. I took it for about 6 months privately through a private doctor. Unfortunately, it wasn't night and day for me. It turned out I was a poor absorber. So I tried patches and gels and upping the doses. And I didn't feel like the benefits that I was getting personally justified the risk that some doctors think that it gave me. So I stopped. And I'm now moving on to testosterone, which I'm sure we'll get into in some more detail. But yeah, now I am only taking testosterone. And an AI, I should say. I do take an Astrazole as well.
Yeah, there is lots to uncover. And Helen, I've known you for a long time. You've been on the Empowered Menopause program. So we've really had time to talk about the nitty gritty of it all. And Lisa, I want to understand your whys, and I want to understand your whys, Helen. What makes a patient decide that you are willing to take a risk, the potential risk? Like we don't really know, like the worst case scenario might be a 3-fold of the rest recurrence we've got. So it's going to kill you at all. It's a bit like we know smoking increases our risks of cancer by X amount. And we also know the worst case scenario, which might be the habits trial, is a 3-fold or a 2.4 fold. So that's the worst case scenario. So it's never a complete and absolute risk, isn't it? So it's really important to talk about that. But I know when we have conversations with our doctors, it's almost like that's it, that's gonna get you. So it's important to sort of step back from that a little bit. But what were your symptoms, Helen, or what were your worries for you to consider embarking on that risk? And what were you hoping for the benefits to be?
So for me, excuse me, the main life-affecting impact was cognition, brain fog. I hate that because that feels quite nice and fluffy, and what I had was not nice and fluffy. I took my dog for a walk one day and brought her back at 8 o'clock in the morning in the car, and didn't remember that she was there till 3 o'clock in the afternoon. I put dinner in the oven, went to go and do something for literally 5 minutes, and then I was going to come back and turn the oven on. But when I got back 5 minutes later, I'd completely forgotten that I'd done that, and I started making a completely different dinner that didn't involve the oven, and only found it again the next morning. I was doing stuff that I saw my 80-odd-year-old grandma do when she had dementia. I ended up going into London to see a specialist because I genuinely thought that I had early onset dementia. So I call it cognitive impairment, not brain fog. And I hadn't worked all the way through COVID and treatment, so I'd actually been out of work for 3 years by that time. Before diagnosis, I'd worked quite hard. I'd had quite a senior career. And I really wanted to go back to work. And I felt that there was just no way. I work in operations management, and it's the key to being a good operation manager is juggling 1,000 balls, and I felt that I probably couldn't juggle 3. So it was largely around that. Having said that, when you have the checklist of things that impact you, I have nearly all of them. zero libido, absolutely no interest in it. You might as well be talking to me about sprout farming. Joint aches, fatigue. I've always been quite active and fit, but now I just do not have the energy. Once I've sorted out my busy family life, I am now back in work, but it can be a struggle. So all of those things together made me just think that, okay, I need to understand what the risk really is. There's obviously various opinions on that. I read the Estrogen Matters book. I read lots of other studies that showed differences in opinion, but ultimately for me, it was about what HRT could give me in terms of benefit. The other conversation that I did have quite often with the doctors I met was, what about this balanced risk perspective? No doctor that I've ever met has talked to me about how I could reduce my risk by keeping my BMI to a certain level, by not taking those 2 units of alcohol a week, by not smoking, by doing, I believe, 2 hours of exercise a week. I wrote it down, 2 hours of exercise a week, -7 in terms of the number of occurrences. There are so many things we can do that are really positive, that no medical professional I've ever spoken to has ever talked to me about. When I asked about nutrition, they said, you're having a tough time, have what you like. But I was actually saying, no, I think this can help me. Can somebody please help me help myself? And my argument to my medical professionals that have sometimes sat on the shelf is that, look, this will help me be more active. It will help me keep my job. It will help me, all of that stuff together. If there's an increased risk of taking this HRT, do you know what? On balance, I'm going to take it, because I feel that for me, it will change my life to such a degree that if there's an impact down the line, will I blame myself? No, I think I will be able to look myself in the mirror and say I did that for the right reasons.
Yeah, thank you, Helen. I think it's so important to understand those whys. And I know we have a lot of doctors listening to our conversations, and they don't always get the opportunity to listen to these very reflected whys from these very clever women. And I always said to you, Helen, from the day one when I met you, I've never met anyone who's done more research than you. And I have learned so much from you. So thank you for being on this journey together, because I really, truly feel like we learn so much from one another. Lisa, what's your why? So you had to come off your HRT, you had your cancer, your surgery, your radiotherapy. You knew to ask what your risks or benefits were of going on the aromatase inhibitors or your endocrine treatment. And they were so low. Like, many people don't know how big their benefit is or how low their benefit is. You knew, you made the decision not to start. But you're early on in your journey. What is your why of thinking to reintroduce HRT?
Very similar to Helen, actually, and I couldn't agree more, is that, kind of like, I was already pretty healthy. I was exercising every day. I'm a yoga teacher, and I also work out. I was sleeping well. So I'm very health conscious, and I read and absorb everything about health before this. So I knew the value of sleep is massive on inflammation in the body, the role of diet and kind of what you eat, the role of inflammation in the body. And before, I think the fact that I'd done a lot of research before I went on to HRT, because of this mental block that it's a last resort. And then obviously there was a growing sort of discussion amongst my peers and my friends about it, because of more highlights in the media, which is great, because the conversation's being had now, rather than it's just, oh, you don't do that, which is what, kind of like our mothers and grandma's generation perhaps, just tolerated it. So I'd already done a lot of thinking. So to me, when I was told to come off it, I was like, oh my God, it was kind of like a real step back. But I was also afraid, obviously, like everyone, didn't want to fuel the cancer, or kind of, so I then went on another mission, a bit like Helen, to really educate myself as much as I could, because I didn't feel all the questions I was asking from different health professionals, I was getting adequate answers. I was like, I don't mind having a conversation and making an informed decision and saying, yeah, actually, you know what, you're right. But everything that I'm hearing is, we don't know. In some studies, there's kind of like an increased risk after breast cancer. In some studies, there's a decreased risk. Obviously, there's all the health benefits of estrogen for other things like bone and brain and blah, 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 and all of these emerging fields. So it was so confusing. And so I kind of had to sit with that and sort of sit down and, it wasn't something I took lightly at all. I had a good conversation with my husband, read up lots of things, did a bit of jiggery pokery on the Predict app as well, the NHS tool, which is what my oncologists use, and came up with some questions for them, again, which I'm still yet to have a conversation about. But one of the things I did is put all my markers in there, and sort of I put on there that I was exactly as I am, and we could see that there's a low risk of only a marginal increase with your aromatase inhibitors. So then my logic was, okay, so if I was pre-menopausal, therefore I had my natural estrogen, what would the outcome be? Just kind of my logic as a layperson was, well, that would make sense that if I had estrogen, that would then come up as a higher risk of death or reoccurrence or whatever. And there was no change. So I was like, okay, that's interesting. I'll ask. I put a letter, as you said, this is my assumption. Can you tell me why that would be? So I kind of wanted to just make as much information as I could to make an educated decision, which was right for me. And then the balance of not sleeping, cutting out alcohol, all the things you said, being active, and all the things that were more difficult for me when I was having menopausal symptoms, particularly exercising regularly and eating better. Because obviously if you're not sleeping well, you tend to not eat as well. I don't anyway. You crave kind of more sugary and starchy foods. Whereas when I've had a good sleep, I'm quite, very, very whole food, plant-based. That's what I eat. So to me, it was kind of like this tension. And so I spoke to my GP, and my GP said, I'm on board with everything you've said. I agree with you. There's not the evidence one way or another. I can see your very low risk of reoccurrence. However, I can't prescribe it without oncologists say so. So she wrote to the oncologist. The oncologist wrote back saying, yes, it's a low risk. We support her rationale behind not taking the anastrozole, although that is still my recommendation to take the anastrozole, the aromatase inhibitor. We do not support the reintroduction of HRT. However, I do recognise that there is no guidance on whether it should be reintroduced or not. This is what her letter said anyway. So it's really a prescribing GP's decision with the patient to make an informed decision. And my GP just wasn't happy with that and wrote again and said, could you clarify? Because I thought it was very clear what she was saying. But anyway, so I felt between the oncologist and the GP. I wasn't sure what to do next. And now I've been referred to menopause clinic. So hopefully I can have a bit more of a nuanced conversation with them. So that's the kind of like the background to it. All the while I've got all these questions. And I just thought, you know what, I'm suffering. I've got a grandson who I'm not being present with. I'm not sleeping well. I had some HRT left. And I just made a decision, I'm going to start again. And literally within a few days again, I was sleeping well, like the first time. My hot sweats had stopped, the palpitations had stopped. I felt my old self. And then I ran out. And then, quite frankly, my friends have been supplying me, which is not correct. I know it's not the right way to be, but I'm going to be completely honest. They've been giving me their leftover bits in order to see me through till I see the menopause clinic, hopefully within a month or so I can hopefully get properly monitored and discussed with them to have it through the NHS.
Lisa, would you be willing, if it came to an agreement, say, between you and your doctors, because at the moment you have been failed. No one wants to hold the risk. Your GP doesn't want to hold the risk. Your oncologist is not happy to make a shared decision-making process with you, right? He or she is not happy to hold the risk. The menopause specialist might not want to hold the risk, because I know so many people who go to the menopause specialist to have those conversations. And again, they're walking away without the conversation, and especially without HRT. Would you be happy to hold the risk?
Yeah, I've put that in both letters to my oncologist and my GP, that I'm 100% happy to sign a disclaimer, that there is no, if that's what's necessary, that this is completely my decision based on an assessment of my risk versus benefits. I'd love that to be a joint decision, But I'm happy to sign any disclaimer that's necessary for them not to feel that it would be kind of anything to do with them. So I've already put that out there. That wasn't acknowledged in any reply. It was really just...
No. Yeah, because they also probably don't have guidance. If anyone has listened to every episode of the series and go back to episode number 2 with Professor Richard Simcock, this is exactly the problem they have, is doctors have not got the guidance or the support or the know-how of helping patients. And yet we know shared decision making exists, and it needs to, and it should be practiced, and we know it's not happening. And really, you are not allowed to make that risk, Helen, or you're not allowed to make that choice. Helen, who do you feel holds the risk as a patient, as someone who has really thought about this subject a lot? It's a difficult decision, right? If there is uncertainty, I think many doctors will say, my priority is to not do harm. And if I can't prove that I'm not doing harm, I need to stay away. I really see that point. Talk to me about your thought processes about that. Risks, who holds it, shared decision making.
That's really hard. Yeah, it's a really hard question. I'm not a doctor, and I can't imagine going to bed at night thinking, I wonder if I've done the right thing about somebody. They have to feel that in their heart and everything that they've learnt, they're doing the right thing. I guess in my experience, there are, well, no, there are, it's not that there are none, but I personally, and I've looked hard, there are no specialists in menopause after cancer. Hence why you're a hero, Dani. There are plenty of specialists in, there's my headphone gone, plenty of specialists in oncology, and they will hopefully, if you're lucky, help you with your cancer, heal your cancer. And there are a few menopause specialists, but never the two shall meet. And that is the black hole. I've spent probably over a year on 2 different menopause specialist waiting lists. I got discharged from one after 10 months incorrectly and had to go back on to the back of the queue. And I'm just back in there now. And it's been really interesting to me because the initial conversation with them, with a more junior person, but an incredibly understanding conversation where they say, we understand that this is about patient centricity. This is about understanding that this isn't about reading the back of a drugs packet and seeing what nice guidelines say. This is about understanding your patient's lived experience, and we get that. When my case was taken to the MDT, though, it was very quickly rejected. I asked for testosterone implants, which, to be fair, is probably a little bit out there as far as treatment goes in this country anyway. This is whole other conversation about how it varies geographically. But yeah, it was a no. So I asked in no uncertain terms to speak to whoever wanted to say no to me to understand their thinking and so that I could put my side across. To be fair, the lady, a senior consultant at a London menopause specialist clinic, she did hear my point of view. She did try and persuade me to try testosterone gel instead of implant because it's much easier to reverse, and that was her concern. But it doesn't touch the sides as far as the type of dose that I personally need because I'm not taking estrogen. And she did listen, and she did say, okay, if you are accepting that this risk is on you, which I absolutely am. So there are pockets of doctors that will listen, but I think the thing that I found the biggest failing is that doctors will sit with very poker faces and they will say, no, you can't do that because X. And I know that the studies show different to what they're saying. And instead of saying, do you know what? This isn't really my field of expertise. I understand that you need help, but I actually can't give it to you. Let me find someone who can, or let me educate myself. Even better, let me educate myself. Let me talk to my colleagues about this gap. Because what happens is the silos exist and we bounce between the silos, trying to spread this knowledge as lay people. I have no medical background. I purely know what I know because I've read very specific stuff about this. But yeah, that was a long answer to a short question. Where does the risk lie? I just wish doctors would or could just listen to this lived experience, and this is, why I wanted to share this today.
Yeah. I want to talk a little bit more to you, Helen, of when you then stopped the tamoxifen, because I want to know about that thought process, but we'll get to that in a moment in my next question of why you're even thinking testosterone, because that is a whole other conversation. And what's so fascinating by meeting so many of you and not just having a 10-minute conversation on social media, really, really understanding you is HRT after breast cancer are many things. I've met people who are on testosterone gel after triple negative cancers because they think it's better than progesterone and estrogen. I've met people on pellets who are on aromatase inhibitors, and people like you, Lisa, who go back to their normal HRT regime because it's worked for them in the past. So there are many different ways of even introducing HRT back into the body. Lisa, what are you hoping? So tell me what you're hoping for the conversation to be like when you see the menopause specialist that you have been referred to. So your GP, your oncologist both said it's a good idea. It's essentially her choice, but I'm not happy to prescribe it. I'm not happy to hold that risk, even though you're saying you hold the risk. Tell me what you're hoping for the conversation to be like.
What I would love is to, because as I said, it's all in writing because I wouldn't remember it otherwise. So I wrote all of the kind of questions about my rationale, some of the lack of evidence and kind of therefore risk versus benefit. I would just love to sit down and say, kind of have a discussion about whether my assumptions are correct, ill-advised, kind of like not correct, or whether there is something I'm missing as to why, kind of it's too risky versus the benefits that I'm seeing. I think but I'm not naive enough to think that, kind of is definitely the case, but I will prepare for that to be the case. Hopefully I see someone who's open-minded, who can have an informed discussion about the whole person rather than just the breast cancer. That's my hope. What should be the whole journey, shouldn't it? That's your GP, general practice. I understand oncologists, they're really focused on the cancer, but we're not just the cancer, are we? We're a whole person, as you said, and all of those other elements that impact the life. That's my hope. I'll feedback as to what happens and where we get.
Lisa, and how does it make you feel that you are a grown woman? You come across as intelligent and reflected to me, that you're not allowed to make a choice of how to live your life. I speak to bodybuilders who buy steroids off the black market, who are very bad for their long-term health, right? Yeah. No doctor would prescribe these steroids to them, and it happens left, right, and center. People smoke after cancer. Some people stop. Many people drink. They use drugs. Yeah. We hold risks in so many different ways. And yet for you in your situation, you're clearly not allowed to make the choice. And you're almost having to resort to make that choice to getting HRT off your friends, which I can hear in your voice is not making you feel good. We know we shouldn't be doing that.
And equally,
how do you feel that you can't make that choice?
And also, there is what I was reflecting on this morning, because you can buy HRT over the counter in most European countries. So, it's kind of like when I went to Spain last, estradiol, similar formulation you can buy. So it's not that it can be stopped, and it's cheaper than private. It's like, so the Spanish women have a choice to buy it. They don't have to be prescribed it, for example, probably the same in most of Europe, actually. And so there is. So how do I feel? What I feel is firstly unheard, but I feel a little bit more worried, because what I would like to do is, obviously after cancer, you have I'm thoroughly checking. I've had my first year mammogram. That was clear. But, there is this worry that it can come back, of course. However, it can come back with or without HRT. But I do worry that actually by not feeling heard, if something didn't feel right, I would have a reticence to go back because of judgment about your choices. Now, whether that's in my mind, and I'm not going to let that stop me. If there's a problem, I'm going back and I'm talking about it. But by sort of saying, we've kind of like, we said no to this, it makes you feel a little bit like you're being naughty and not a grown 54-year-old woman with a grandson, that, you know, kind of you're doing something that's just kind of a bit naughty and frivolous. And it's actually not. It's like, this is really important conversation. That's my honest decision, is that, you know, kind of, it has felt like there's a bit of a barrier between me and my healthcare now. Not to say that I won't go back, but it is much harder to be honest and open with someone who hasn't had an upfront dialogue with you. And I'm sure they didn't mean to.
I think in the grand scheme of things, when you look at all of the people that are living after a breast cancer diagnosis, it's a very few people that want to even consider HRT after breast cancer. Like, I know it's a big topic, it's controversial, it's emotive, but really, when I speak to 100 women who are after a breast cancer diagnosis, very few want to even talk about HRT after breast cancer. But the ones that want to talk about it, it's really important to them. And every single one of them I have met so far has been under-supported and underserved. I haven't met with many people who have been very much supported in their decision or in exploring this. Helen, I'm going to go back to tamoxifen. You've done about 2 years on it. The side effects were bad. You decided to come off it. But your risks and benefits, your benefits of the staying on tamoxifen were actually greater than Lisa's, weren't they? So it's important to differentiate here as well. Endocrine treatment isn't just endocrine treatment. You had a more significant benefit to stay on this. So when we met, you were off tamoxifen. You hadn't started the aromatase inhibitor. And I know you felt a bit of a pressure. You were like, I need to make a decision. I'm reluctant to go back on tamoxifen. I'm worried. I don't know if I can start aromatase inhibitors. I'm worried about feeling as bad as I did. And you were in this la la land. And I remember saying to you one day, but not making, yeah. And I was saying to you, but not making a decision, that is also making a decision. But you had a pressure on you to do something about it almost. So what did you decide to do then?
So I came off the tamoxifen for my surgery, and I kind of just didn't go back on it. And I thought, well, it'll be an interesting experiment. I had been told by my oncologist before that I could come off it for sort of 6 to 8 weeks without significant effect on risk. So I thought, well, I'll just give it a little while and see what happens. It just so happens that I had a scan because I had some back pain, and they found a major thickening in my womb, and I had to have an emergency hysteroscopy, I think. And they found that tamoxifen had actually had some quite bad effects in my womb, and had they not have found that could have turned cancerous as well. That was the nail in the coffin as far as tamoxifen was concerned. By this time, I knew I was post-menopause because I'd been on HRT, and the blood tests hadn't been able to confirm my estrogen was actually -18 or whatever the through the floor figure is. Whenever it's been tested, when I'm not on HRT, that's where it is. My kind of diagnosis, if you like, or being told that I was actually menopausal, was kind of delayed. But by this time, I'd managed to get my oncologist to agree that I was postmenopausal. So he suggested I go on to an AI. I could not bring myself to do that. The thought of going anywhere back to where I was makes me emotional even now. So I delayed and I delayed and I delayed. While delaying, though, I researched, and that's where I found out about testosterone implants. In this country, at least at the moment, it used to be more common, but it's very unusual in women. But in the States, they're much more common. So they're a tiny little implant of testosterone at very high dose, but it gives a real regular release. And in that way, it can counteract some of the menopausal and the symptoms that the AI may cause in some people. So I decided that I did want to take an AI because my numbers are about a 4 to 5% improvement in terms of recurrence. But I would not take it on its own because the thought of going back there was just intolerable. So I looked for testosterone implants, and that's where that kind of came along, that I did want to take the AI, but only with that backup, so that they could kind of hopefully balance each other out.
So we have a podcast episode with Dr. Rebecca Glaser, which I'm going to link into the show notes here. I'm not going to include it into the whole HRT of the breast cancer series, but if anyone is interested, Dr. Rebecca Glaser is an American-based physician, and she's done a lot of research on the use of testosterone pellets, so the implants, like Helen explains, for those who are on an aromatase inhibitors. There are no randomized control studies, but she has got studies with hundreds of women from her practice, and there's lots of interesting information around that about the benefit, the symptom improve, and even outcome of survival, isn't it, Helen? And so it's really so fascinating to speak to both of you today who have been exploring different versions of HRT after your cancer diagnosis. Because, Helen, I am wondering whether you're now hoping that the testosterone is going to allow you to stay on your aromatase inhibitors. And really, we want people to stay on the endocrine treatment if they see a significant benefit from it, right? Because we know less than or about 50%, 60% don't finish their treatment because the side effects are too severe. Is this your hope that by doing this, you can stay on your treatment and mitigate some of the side effects?
Absolutely. Yeah, absolutely. No, I want to take it. I do want to take it. I want to push the needle in the right direction any way I can. And that's why I, mention all the lifestyle changes and things like that. I'll do what it takes. But yes, it really is a fundamental part of me being able to stay on those AIs. Yeah.
I think in general, the only way I want to round up this conversation is to say it's really, really hard for all of us at the moment, isn't it? It's really hard for patients, and I'm sure it's really hard for doctors. It's kind of like new territory for everyone. And all we can do is really just have more conversations. And I wonder how long it'll be for many more doctors to be comfortable to have these conversations. I know there are many, many women sitting in the dark at the moment. We've just put out some workshops of who wants to talk about HRT after breast cancer. We allow 50 people per workshop, and we were fully booked twice within 3 hours. So I know there are hundreds of people out there who just are desperately wanting the conversation. They don't even want HRT necessarily. They just want to talk about it and hear others talk about it like you did today. So I can't thank you enough for being brave enough to just share what's happened for you. So thank you both.
Pleasure, Dani.
Thank you, Dani.
Hope it's helpful to some people out there. Thank you for everything you do.
I'm going to leave it here, the conversation. I could carry on talking to these women for hours and hours on end, but I think I'm going to leave the conversation here. It helps us understand what our thought processes are, how we're feeling. And these women are just amazing. And they're brave for coming on here and sharing their stories. And I have hundreds and hundreds more women in a similar situation who are also inquiring, researching. They're on their own thought process. They have their own worries and their own fears, their own hopes, their own desires. And it is my hope that together, by sharing these conversations, we can start to build really good doctor-patient relationship collaborations so that we can all have these conversations in a much less judgmental way. Now, I'm going to leave the mini-series here for now, but I know I will add to it as time goes on. In the last few weeks, I've hosted a few workshops with women in our community, and we had over 180 women join our workshop conversations. I didn't want to record them and share them with everyone because I wanted people to feel really safe in these conversations and say what they want to say. And it was amazing. We had people from all over the world join these conversations, and it just allows them to have a space to share what is going on for them. And that's what my aim is with all of these podcast series, the HRT After Breast Cancer series, and any of the other conversations we host. So for now, I'm going to end the HRT After Breast Cancer series here, but there might well be many more episodes coming in the future. If you're listening to this on the podcast, then next week I've got an amazing podcast coming out for you on sleep with the most amazing sleep and menopause expert, Dr. Zoe Shadell. And I can't wait for you to listen to that, should you feel that you might want to improve your sleep a little bit. With that, I love you and leave you. Thank you so much, everyone, for tuning into our conversations. And yeah, let's keep on talking.